Thanks, Bernard. You're right, I've been here a while, but they haven't given me a better parking spot yet, so if anybody can help with that, that'd be great. So this is the 11:30 slot, and I think once you get into the 11:30 slot, you're obligated to say that you're one of the few things standing between you guys and lunch. I think there's actually another speaker, but I'll try to go through some things quickly just to give you an idea of the importance of integration. And I think that one of the reasons that Bernard asked me to talk about this, and congratulations for putting on another great symposium, is really that mobile health, I think, really shows a unique data collection platform that I know a lot of people have spoken about today, but that it could really provide even more value and be augmented if there is a true integration with the current healthcare delivery system platforms. And so I want to talk a little bit about both HealthKit and ResearchKit, which Bernard had mentioned, and certainly in the context of care delivery for HealthKit and clinical research for ResearchKit. I'm not an Apple apostle by any means, so I'm not here to talk just about those two, but I think they might show you some good examples of things that we're currently trying to do at Duke and how we might be able to use some data that's generated by patients to really improve their care. So why should we do that? I think one of the first things that's always very important to remind ourselves about is really the issues that we're facing in this country, and I think globally in terms of healthcare spending, and the need for us to really think about novel care delivery models and more cost-efficient and effective models of care. This is from the Congressional Budget Office. This is their 2014 long-term budget outlook. And I think it's always important to see that, certainly there's a lot of issues in terms of our debt continuing to increase. But the thing that's very important to take note of is also the trajectory of the federal spending on the major healthcare programs. And you can see that this is eclipsing other non-interest spending, Social Security, net interest, and perhaps growing at a quicker clip as we get into the next decade. So with that in mind, I think it's very important to think, how do we really transform or evolve healthcare? And this was from Frost and Sullivan, which really said that, right now we're at the left side of this arrow. So right now you think about the show ER and about heroic medicine, and for us really taking care of things that in the throes of a crisis. That's sort of what our healthcare system is right now. We really wait till something is broken to fix it. We're reactive to disease, not health or wellness, and we take care of that in person. So it's not very easy for us to manage a population of elderly patients or people with chronic diseases if we're going to really continue in that model. It's a very expensive model. So what we'd like to do is start to move down this arrow and think about how do we start to do more in the home, more outside the hospital, which may be a more cost-efficient way to do that. But to do that, we need to be not in a break-fix mode, but maybe more of a semi-reactive mode where we're starting to preemptively intervene on some of these patients, and we have to do that by being more connected with those patients. And I think that's where we start to really see the value of integrating data from healthcare systems with data that patients and consumers might be collecting in ambulatory settings. And ultimately, I think the goal is to, if we really want to manage population health, how do we really provide preventive health? And to do that, we truly need to be predictive and not waiting for a disease, but anticipating when that's going to occur. And to do that, we really do need to monitor patients and end users and be able to understand how to use some of those data sources well with what we do. Right now, I think we do a great job in hospitals, for example, of collecting data and being able to act upon that information. So you can think about the healthcare provider. They certainly document a lot. Everybody knows how much providers spend in Epic in terms of actually charting what's going on with the patient. A lot of valuable information there. We do a lot in terms of imaging, in terms of understanding from an image perspective what's going on with the patient. And then there's certainly a lot of streams of data in terms of continuous monitoring of these patients on an inpatient setting. And those are really great examples of how we might be able to use that information to make clinical decisions at the point of care. So in the hospital, I think we have a good sense of how this might work. What we don't have a really good sense of is if we're going to start lower the cost of care and really change the way care is delivered, how do we transition care from the hospital and into the home, or at least outside of the hospital? And to do that, we really need to start to think about how do we move from those sources of information that we're collecting in the hospital to ones that we might collect out of the hospital if we're really going to get actionable information outside. But the issue right now is that data is really siloed according to users and venues of care, and we don't have a good integration of the data collection platforms. If you think about all the things that a patient collects, it could be everything from patient-reported outcomes to vital signs that they might collect on the outpatient side, and I'll speak a little bit more about that. Tracking their activity, sentiment analysis through social media, and even geospatial mapping. These are all examples of data sources that we might be able to use to better predict when diseases are going to decompensate and better identify those people who need interventions before they actually need them. And that would provide us with a way to progress down that evolution of healthcare. Let me give you one example of a use case, and Bernard mentioned this. One of my clinical responsibilities is helping to run this clinic called the Duke Heart Failure Same-Day Access Clinic. And I would like to use it as an example of how we might be able to do better if we were having a way to integrate data between the hospital and the home to provide more efficient care. Heart failure is one of the leading causes of readmissions among elderly Americans, and it's a really point of emphasis for healthcare systems now. It's publicly reported on websites like Hospital Compare, and we're financially penalized for excessive readmission rates. But there's not really a good way for us to get some of these readmission rates down. And as a result, the United States alone spends about $37 billion on heart failure every year. So one of the things that we've tried to do is think about how do you start to move some of the care outside of the hospital. And we created this clinic called the Same Day Access Clinic to really provide care to patients every day of the week, at least Monday through Friday, so that they could access a provider rather than go to the emergency department of the hospital. And we also wanted to provide some more intensive services on the outpatient setting in this clinic. So just like they might get intravenous therapies if they came to the emergency department of the hospital, we now provide that on the outpatient side. So we're providing them with an alternative care path for some of the patients who might not otherwise have an option except to present back to the ED or the hospital. And so for a lot of these patients, they may have symptoms such as lower extremity swelling, shortness of breath, things that might need to be urgently treated. In some of those patients, I'll give you an example. I see patients with Jay Kelly, who's here on Fridays in this clinic. We often IV diurese some of these patients and get off a lot of fluid, a lot of weight, allowing them to breathe better, and then see them back in the clinic on Monday, and it's nice to see and be rewarded by an improvement in their symptoms and helping them avoid the emergency department or hospital. And so we really want to think for a lot of these patients, how do we provide this alternate care pathway where we improve disease management on the outpatient side so that they don't need the ED or the hospital. And certainly there are some patients who will go on to need that, but if we can really improve what goes on in the outpatient setting, then perhaps we can be better stewards of those resources that are expensive, like the emergency department or the hospital. To do that, we really wanted to think about how we might be able to monitor some of these patients better, and this admittedly is not an mHealth approach. This is an example of data that we collect with some of the remote monitoring systems that are out there, and some of these systems are a little bit antiquated compared with some of the data collection approaches that we are talking about today. But here's an example of one of my patients' weights that we collect on a daily basis in the home, and we can see certain trends in the weight. And so for a heart failure patient, monitoring somebody's weight on a daily basis can be a very useful measure. We tell these patients that if they gain, say, 2 pounds in a day or 5 pounds in a week, it may be time to call us because it may be that they're getting more fluid on their body and they're gaining weight from that. And so it may be a useful time to think about adjusting some of their medications. And you can see with this patient here that perhaps they were getting to a point that they really need to see somebody. Unfortunately, a lot of these patients don't have the system. They don't reliably track their weight at home, and so oftentimes they're coming to us more in the ER style mode when they're acutely short of breath, and now we really need to think about doing something like a hospitalization. So one thing that we want to really do is think about how do you really scale up an approach like this, and this is where I think as a use case, the Same Day Access Clinic provides a good way of thinking what would mHealth do if we were able to scale up our remote monitoring capabilities. What we'd like to do is think about not really putting that expensive remote monitoring system in 5 or 6 patients, but really how do you take something even like a consumer or off-the-shelf scale and be able to get constant data streams for some of these patients if they just step on their scale once a day, and then have somebody like a nurse clinician be able to triage those patients so that they see that some of the patients may not have a worrisome weight trend and they are doing fine. We can just let them be as they are at home. But for those that are, we are able to have somebody triage those to a stable provider who might be able to see that patient on any day of the week and really be able to help the patient make meaningful sense of the information they're collecting at home and improve their health and wellness on the outpatient side. So one of the things that we undertook about half a year ago was really thinking about how we might do this with HealthKit. And I think this is getting to the point where we want to talk about the value of integration between patient data collection on the outpatient side and what we do on the inpatient side through the electronic health record. And this is an example of a press release that came from Reuters half a year ago about what we were doing to track blood pressure, weight, and other measurements for patients with both cancer. We're looking at patients with renal cell carcinoma and heart disease, in this case heart failure. And so this is what we did. We actually built an integration where a lot of the data that might come from an off-the-shelf device like a Withings wireless scale or a Jawbone Up or an iHealth blood pressure cuff, how we could get some of that data directly into the electronic health record so that that's where the providers are actually working every day. They could start to see some of the data that the patients were collecting on the outpatient side and start to really intervene on those patients in a more timely manner. You think about what we do with chronic diseases right now. There might be the diabetic patient who comes to clinic and has a diary of all their blood sugars that they've taken for the last several weeks, or the heart failure patient who might be keeping a log of their weights. This is a way for us to really have access to that in a real-time manner so that we can start to see what those trends are and intervene preemptively. So what DHTS at Duke helped us do was really think about how do we use Epic's MyChart app and HealthKit to really build this integration. And we now tested this, and this is actually data from one of our patients, where a patient may be wearing the Jawbone every day, maybe stepping on the Withings wireless scale and using the iHealth blood pressure cuff to obtain measurements. And those are all essentially collected and aggregated through HealthKit and passed into Epic through Epic's mobile app, which is called MyChart. But what's beautiful about this is that for the providers, where we're sitting every day, which is in the desktop interface of Epic, we're able to pull up a flow sheet which allow us to see all these vital signs that are collected by the patient just as if they were in the clinic. So right now, most of the clinics are only able to see these types of vital signs if the patient is coming into the clinic, stepping on a scale in front of us and having us measure their blood pressure. Now the patient is able to do all this on their own, and we're able to see that information so that we might be able to intervene on these patients. So this is an example of one thing that we're doing as a research study. Incidentally, this patient actually ended up coming back to the hospital, and we looked back at the data that he was collecting at home, and we saw that he had gained 9 pounds. And if we were doing this in a real clinical arena, we would be able to actually have preemptively intervened upon this patient. So we think that there's really useful data that's coming from some of these tried and true metrics like weight or blood pressure. And I think where we'd like to go is this is really a scalable model, because once we start to have a way of really integrating what's happening with patients or end users on the outpatient side, we can start to think about how we might not only serve heart failure patients, but all sorts of patients with chronic diseases. So in blue here is a representation. We might have heart failure patients who are stepping on a scale, and maybe the cardiologist monitoring that. But you could also have patients with diabetes be able to wirelessly send their measurements from their glucometer to the endocrinologist. And then you might have patients who have asthma or COPD who are using albuterol as a rescue inhaler. And you might have a pulmonologist who's seeing how often they're using their rescue inhaler so that they can start to titrate their medications. So for all these chronic diseases, again, remember that healthcare spending trajectory. If we're really going to affect that, we need to think about how we better intervene on these patients with chronic diseases on the outpatient side. And I think a lot of it will have to come down to how do we really integrate all these different types of devices through somebody who can monitor them and then somebody who can treat them. And for a lot of these patients, you know that they don't have just heart failure or just diabetes or just COPD. They might have all three or more. So this is really an example of how we might be able to manage complex patients with multiple comorbidities at home in an efficient manner. So those are examples of maybe the way that we might monitor patients with metrics that we know now, like weight or glucose or the use of a rescue inhaler. But there's a lot of different other things that we might be able to do, and this is where I think this group could really play a role, is how do we start to use some of the other data sources that might be really interesting for patients. So there's patient-reported outcomes that we might be able to use in terms of understanding how patients are doing, what's their quality of life, are we really improving that? There may be things we can do about activity tracking that we can talk about later. And there may be things that are very interesting from a sentiment analysis or from a geospatial perspective. And a lot of you probably know, if it hasn't been mentioned earlier, that there were some interesting recent studies about even just an analysis of Twitter and understanding that the language that was being used in Twitter could really predict heart disease geographically just as well as the CDC could with epidemiological estimates. So there's a lot of different ways that we might be able to think about how to use these novel data sources. And I think that's where we start to think about what can we do from a clinical research standpoint. And there's certainly a lot of opportunities here, and I think this is really being blown open, not only by ResearchKit, but a lot of other, I think, data collection platforms that are coming down the pipeline very soon from other people as well, from what I hear. But to talk a little bit about ResearchKit, because this did get a lot of press recently, this is, as you know, an open source platform to really improve data collection and really scale up what we can do on a clinical research side. And there were several apps that were released with Apple's announcement, which include these different conditions, including breast cancer, diabetes, Parkinson's, cardiovascular disease, and asthma. And there's a lot of different modules that you all are probably already familiar with that you could start to conduct a large-scale research study within ResearchKit. And I'll talk about just doing a study alone in ResearchKit, but I think the value really is how do you integrate that with the health data that the providers might be collecting in the hospitals and clinics. But to talk about ResearchKit a little bit, first you can really improve the informed consent process. And one of the things that you all may be participating in some of these studies, as you know, you can start to even consent for a study by just interacting with the app, going through a few screens, and then signing for the study. We've actually developed something like this at Duke even before ResearchKit was announced, and Mike Revore and Jamie Danley, who are here, now have an app which they may be happy to speak with you about, where we're actually doing informed consent on an iPad in a multi-center study across the United States. And this is an example, I think, of homegrown innovation where we've really thought about how do you really change the consent process and make it very simple, multimedia, and interactive so that patients can not only see who's conducting the study like a study investigator and have them talk to them about the study, but also sign for the study and consent. And I think a lot of the elements that Apple has put into ResearchKit, I would like to think they copied from you, Mike, so maybe we need to sue them. And then there's also the opportunity to collect surveys, and I think this is an example of how we might start to really understand from a patient how they are doing in terms of patient-reported outcomes, validated survey instruments. This is, I think, a huge part of what people will be doing with ResearchKit is actually conducting survey-based studies. And lastly, I think this is one of the innovative aspects, is using a lot of the features within an iPhone to really conduct active tasks within a study. And you probably saw a lot of these during the Apple keynote, where they may be using the accelerometer and the gyroscope to understand the gait of a patient with Parkinson's. They may be using, for example, the microphone to understand phonation, again, with the patient with Parkinson's. But there's also a lot of other opportunities, and I think one that we're interested in is how do you really use the accelerometer to understand a patient's functional status. And Jay Kelly and Nick Weisham, who are here, are doing a study where they're going to be looking at the use of an accelerometer and comparing that with the 6-minute walk. This is an example of a test that we do in the clinic to understand a patient's functional status, but we don't use it that often because it's not a very efficient thing to do in the clinic. Now that somebody has in their pocket a way to conduct 6-minute walk tests at home at any given time, we can really start to understand what a patient's true functional status is at home. And so Nick and Jake will be looking at this in COPD and heart failure patients. But this idea of getting novel data that can be quantified and really brought at scale, I think, is one of the real opportunities here. ResearchKit really provides, I think, an ability to really provide a large-scale study to patients in a very quick manner. I spoke with Mike McConnell, who is one of the investigators from Stanford who is doing the cardiovascular app, and I spoke to him 2 days after the ResearchKit announcement, and he told me that he already had 30,000 downloads with 15,000 people consented. 15,000 in 48 hours. That's a large-scale study. So I think people really need to think about how they can incorporate this into their research. projects, because this really might be a great way of collecting some data. It's also going to be open source. This was actually, I guess, formally announced yesterday. I think there's still some questions about how this might port to Android and other platforms, but certainly I think the sentiment is there for this to be really a collaborative platform. It really can help us, I think, with patient-reported outcome collection as well as some of the novel measures. But I think there's going to be a lot of disadvantages to this too that I think we need to think about very carefully in terms of missingness of data. I think even if 15,000 people consent, how many are really going to go through the whole study? I can tell you I'm one of the 15,000 people, and I haven't answered one of my notifications yet. So the app keeps harassing me to do 6-minute walk tests, and I haven't done any. So how much data will you really get from the patients who are participating? I think that's a question that's still out there. There's also obviously a selection bias in terms of who is actually signing up for these studies and how they're reporting it as well. So one of the issues that you hear, I think, is even if it's a large sample, if it's a skewed sample, it's still skewed. So I think we need to acknowledge some of these biases, and this is going to be an issue for us. And then I think lastly, as we start to make a more open source platform here, I think we're going to have to make sure that we understand how we're normalizing data that's collected by different platforms, whether it's Android or iOS. But at the end of the day, I think if we're able to get some of these novel aspects that we might collect from patients, again, we can think about going back to that first model of what I showed with the same-day access clinic, and think about how you might use some of those novel data sources to meaningfully act upon these patients in a different site of care. And I think that's the message that I'd like to drive home, is that we need to decentralize what we're doing from the expensive hospital into the clinic and eventually into the home. But to get there, we really need to be equal partners and stakeholders with patients and make sure that we're not siloing our efforts, but really integrating not only the data, but what we do with the data across those different venues. So I'll stop there and take any questions, but thank you for the opportunity. Yeah, no, I'm glad you brought that up. I guess I'll start off by saying that one of the concerns that I think a lot of venture capitalists, a lot of clinicians have about a lot of the products that are being developed right now is that they all have their standalone dashboard. And so everybody always asks, how are you going to monitor all the data across all those different dashboards? So I showed you one with a remote monitoring platform. That's not integrated with us, so somebody has to jump over to Cardiocom's website and be able to track all that data. So that's one issue I think that's come up. Now let's say we take care of the integration piece. Still the question arises, how do you really scale this up if somebody has to sit there and comb through all of the raw data? And I think our goal is to really make it so that nobody is actually interacting with any of the raw data. And so what we're working on right now is clinical decision alerts that really allow somebody to understand when somebody has crossed a meaningful threshold. So it may not be looking at that trajectory of weight, but understanding that a patient has gained 5 pounds, their blood pressure is over 200 millimeters of mercury. And when they get those alerts, really just intervening on those rather than the raw data, because you're right, you can't take a panel of patients and expect to have somebody comb through all that. But if we set up the meaningful thresholds, I think that's when we can start to really scale up our efforts.
Hi, thank you for your presentation. Alicia Carpenter from UNC Chapel Hill. I was wondering, you had talked about uploading a lot of patient data to the medical record. I'm wondering how you are going to present that information to providers so it's easy to digest and they're not overloaded by information. We had been doing a study with an potential asthma app, and the providers point blank told us they don't want any information uploaded that the child collects into the medical chart. So I was interested in your perspective or experience with that.
I think it's a great question, and it builds nicely off of what Bernard asked. I think this is a good example that if we're going to integrate data from the patient with what the provider collects, we need to make sure it's something that both parties want, number one, and number two, we make it very manageable. And so, we've thought carefully about how we would do that in the same-day access clinic, for example. And I think there's two issues. One is really providing those clinical decision support alerts rather than just the raw data streams to the providers. The second is really thinking about how you might have somebody interact with the data who is not the end provider. So what we have, and what I put in the diagram, was really a nurse clinician who might actually do the clinical triage off of that, because you're right, all the providers are busy, all the pulmonologists won't be able to see all this data from the asthma patients, but perhaps there is somebody who could do the clinical triage just as they do now. So what we have right now with, I'm sure your clinic and others, is somebody who actually manages the triage line is getting calls from patients. It's not necessarily the provider who's getting them. This, in my mind, is just really translating that to a more intelligent way, where instead of getting the phone call from somebody who's doing really badly, you're just getting somebody to man those incoming data streams. So it's the same model, but again, there's somebody who's doing a layer of triage before it gets to the provider. In both cases, the provider doesn't want to and doesn't have to interact with that.
Thank you.
Thank you for the presentation. Zubin from Cactus Group. You mentioned Android development. Do you have plans to look at taking in data from other sources as well, like the HealthKit platform or other platforms like that?
Yeah, I think we definitely do. And again, I certainly don't want to seem Apple-centric here. So I think anytime that we have an ability to consolidate this down and simplify it for making clinical decisions, the better. And I think what we'd like to do is figure out how to integrate better with Android and some of the other platforms. I think one of the lessons that we learned, and it was obvious from the beginning, is that a lot of the patients who may need this kind of effort the most are not going to be the patients with an expensive, $600 Apple Watch or $300 iPhone 6. They may have a very different type of smartphone if they have one at all. So we have a very high interest in trying to integrate some with the Android system. We're waiting to see more from Google Fit, which I think will be one approach for us, integrating things on the Google side. And then on the ResearchKit side, I think we really want to port things over to Android. And so I think one of the first things out of the gate that I know Duke wants to do is really figure out how do we work with Android developers to make that happen. But on both sides, I think it's going to be important, not only for the sake of inclusiveness, but if we really want to take care of this patient population with chronic diseases, this is going to be really important to do.
Thank you for a very thought-provoking presentation. I have a question about integrating other languages and other algorithms that are out there and exist already biostatistically in SMS and SAS and all of those for some of the problems that you elucidated, such as missing data, selection bias, and all of those biases. They already exist, and the algorithms are used in clinical studies already. Is there any movement to translate those things into, say, the ResearchKit, or to combine those languages so that someone writing an SMS can actually have it incorporated into another, or translated into another language, so that you've already got those wheels there and you don't have to reinvent them?
No, it's absolutely true. And I think this is one of the opportunities we have being in a nice academic community, is that if we really think about what do you do with the data once you've received the data, I think that we really have an opportunity to improve this. A lot of people, I think, are going to be dealing with the missingness issue, and that issue already exists in clinical trials, in outcomes registries. And certainly, Bernard mentioned the Duke Clinical Research Institute. We have a huge interest in trying to figure out exactly those problems. I think everybody's going to have some novel way of collecting data through ResearchKit, but I think the really novel thing is if you can figure out some of the statistical ways to get around this. So whether it's imputation or really thinking about propensity scoring on some of these issues with selection bias, what we're really interested in doing is trying to think of some interesting study designs where we might be able to apply those tried and true methodologies. So we're actually in the process right now of an RFP to really find out from faculty and fellows if they have any interesting study designs, because we want to do exactly what you're saying, which is really solve some of those problems, because I think that's where our expertise may lie. But if there are others who have ideas for ResearchKit, please let me know. I'd love to talk.
Thank you very much.
Thanks.